All right, good evening, everyone. My name is John Scalero. I'd like to welcome you to the AO Trauma North America Fellows webinar. For this evening, we're going to be talking about distal femur fractures. The title of our webinar is entitled Nail Plate Both or Other. Like I said, John Scalero from the University of California, Irvine Medical Center in Orange, California, just outside of Los Angeles and San Diego, pretty close to Disneyland down here. I'd like to welcome my faculty. Marshall Burks, is at the Washington University, St. Louis in St. Louis, Missouri, assistant professor and chief of orthopedic trauma, and then Justin Holler, who's at the University of Utah in Salt Lake City. A couple slides from AO North America here. For all of you, you'll be muted. Please enter your questions via the Q&A button on the Zoom application. So that's going to be the area that we're going to be monitoring in terms of the questions you have for us. And please feel free to chime in at any point during the webinar. We're going to be kind of monitoring that and trying to answer them as much real time as we can, and then we'll have some time at the very end for Q&A. So the learning objectives for this webinar: I want you to identify the various fixation techniques for distal femur fractures. Think about some of the indications and roles that either a single implant or some sort of dual construct will have for the fixation of distal femur fractures. And then throughout case presentations, as well as the short talks that we're going to have, identify some of the technical pearls that are being shown by the speakers for fixation strategy to really optimize what's happening in the operating room. So let's just get started here. I think we all know what the problem is. Each and every one of you, and including the three of us, have all seen the various challenges associated with distal femur fractures: malalignment, malreduction, fixation strategies that may not be optimal, loss of fixation, delayed healing, all things that are quite problematic, and not just in the older patients, but also in younger patients as well. These folks, those who are geriatric, have poor bone quality, and many of them very short distal segment fixation, including periprosthetic fractures. And so areas where we're relying on our implants to do a lot with a little amount of bone. There's been an emphasis on weight bearing. We've talked about this for a long time in hip fractures, but there's a lot of growing evidence to show that the morbidity of keeping older patients, especially off their feet for a prolonged period of time, has a notable morbidity. Obviously, the biology in these areas, and you can even imagine, to one extreme, patient who's had a total knee arthroplasty or a revision total knee arthroplasty. Seen the arthroplasty surgeons when they do their arthrotomy, and they essentially skeletonize the distal femur. And if a patient has a fracture around that area, asking that area to heal reliably can be challenging. Malalignment is something that's always problematic, not only with plates, but also with nails. And then the mechanics, I think, is something that we need to think about. What are we asking the implant to do? How are we asking the implant to hold the fracture for healing to occur? We talk about nail plate dual constructs. This is not a new thing, and so if you look back in the literature and you start going back to a period of time before we had fixed angle locking implants, the use of dual plates or kind of intramedullary support was already described by Jeff Mast for endosteal support and recalcitrant non-unions of the femur. Similarly, some of the earliest reports of dual plating were in non-unions, even with locked plating. So, endosteal support, placing something within the medullary canal, dual plating, putting an implant to resist that varus failure that was very commonly seen, is not a new concept. The use of intramedullary nails along with plates is really kind of blown up in the last handful of years. And so, an early kind of small series published in 2018 about this technique in both acute and non-united fractures. So here we are in October 2022, and we have a growing number of older patients, a lot of patients with total knees, total hips, sometimes with both that we have to think about. And, we have this problematic fracture where, non-union rates are still approaching 20% in many series that are put out there. And so everyone's really talking and publishing about it. And so there's a lot of information to kind of wade through. Technology and implant design is really rapidly advancing to keep pace. Implants are being designed with different bends, allowing implants to be placed through different areas of the femur. You're thinking about ways that we can augment fixation to optimize stability. And as I mentioned before, an emphasis on immediate weight bearing, especially in the geriatric population. And, to be fair, a large amount of literature, that gathers some of the data from the arthroplasty world in terms of, replacement, including distal femoral replacements as a real viable solution for some of these problematic fractures in older patients. So I wanted to pose some questions that we're going to try to get to as we discuss some cases, and really what role does an isolated implant, with all this talk about dual implants, what's the role of an isolated locked lateral plate or retrograde intramedullary nail having fixation of these fractures in 2022? When thinking about fixation with a retrograde intramedullary nail, how distal is too distal? What are we looking for in terms of real estate or our implant? When do I need to consider a dual implant construct? And we're going to talk about that when we get to cases and in each of the talks here. What's really the biologic impact of dual plating? It's one of the things that, was initially, before we had fixed angle implants, was done commonly. And then as we relied more on that medial area to be one of the remaining locations of good biology, what's the biologic impact of dual plating? And Justin will talk to us about that. And then in combined constructs, what are we doing first? Does the medial plate go first, then the lateral plate? In plate nailing, is the plate first and then nail? Is the nail first, then plate? And so Marshall will talk to us about that as well as his preference. So here's a general outline. So I'm going to turn things over to Justin at this point and stop my screen share, and then have him talk to us about dual plate fixation, and follow that with Marshall.
Okay. Well, thanks, John. As you mentioned, I'll be talking about dual plating and distal femur fractures, and thanks for having me. So our objectives for this portion are to identify some of the indications for dual plating, review some common myths regarding distal femur plating and when it should be done, and then discuss some technical tips for performing your first dual plating procedure or kind of optimizing your next dual plating procedure. So just overall, dual plating is pretty rare. So in this recent survey that we sent out to traumatologists in the METRIC, or the Major Extremity Trauma Research Consortium, so we sent it out to over 300 traumatologists at level 1, predominantly some level 2 centers, and we got responses from 123. And what they indicated was that only about 18% commonly performed a dual plating procedure, and another almost 40% rarely performed them. So I'd say overall, dual plating is pretty rarely performed, which was interesting to me, because it's really, as John was saying, it's really gained a lot of traction, but it's still not commonly done. And there's some reasons for that, and we'll kind of go over those, but indications for dual plating, at least for me, and I'll certainly offer up my bias in that I think dual plating can be a great option for distal femur fractures, particularly geriatric distal femur fractures. And so these might be stretching a little bit of the indications for some people, but I tried to be conservative. So too distal for retrograde nail. John kind of brought this up, and I think everybody's got a slightly different opinion about what's too distal. For me, too distal is when the medial and lateral kind of condyles are broken off from your periprosthetic fracture, or you're limited on the number of interlocking screws to maybe only 1 or 2. In those situations, I think it's too distal for a retrograde nail, but again, everybody's got a different definition. A closed box for a periprosthetic fracture, situations where you have a proximal implant, whether that's a total hip replacement or hemiarthroplasty, cephalomedullary nail, I think a dual plating construct can make a lot of sense. Significant metaphyseal bone loss with or without articular fracture, and certainly ones that are present in varus, and then some non-unions. And I think the last two are a little bit more controversial, but at least for me, that's when I'll think about dual plating. All right, so these are some of the myths that I thought of when I'm putting together this talk. One is that you'll devascularize the distal femur with 2 plates. Second is that, you'll have a significant surgical exposure. Again, kind of getting back to devascularizing or opening yourself up for increased rates of surgical complication. The stiffness of 2 plates will generate a non-union, and you're kind of limited with how proximal you can go with medial plates. And so hopefully we'll dispel some of these myths. So devascularize, again, something John brought up, and it's a great question. It's something we all worry about. So here's a study done out of HSS where they evaluated the impact of dual plate on the vascularity of distal femurs. And so they had matched pair cadavers where they did a lateral approach to the distal femur, placed a plate, and then they had, I think, several other cadavers in the match cohort that also had a lateral approach as well as a medial approach and had plates posted on both sides. And they did this gadolinium MRI sequence and demonstrated that just the lateral approach reduced the vascularity of the distal femur by 21%. And by having a dual plate construct, there was 25% reduced vascularity. So overall, for math majors out there, a 4% reduction in with that extra medial incision. So for me, I don't think that's a significant impact to the vascularity of the distal femur. Others may disagree, but that's the evidence that's out there on that. The next is that, is it a significant exposure? And I'd say in general, nowadays, I think there are plenty of technique articles out there that describe this as being pretty minimally invasive. And so here's an article, a recent JOT, where they demonstrate a medial based incision that you can then see in the slide to right, that you can then incise the fascia of the VMO, and then you can elevate the VMO anteriorly and slide your plate, which is the last photo on the bottom. You can slide your plate proximal, have a more anterior based incision where you can find the proximal in your plate and place your screws, and you can do all this fairly minimally invasive, almost like you do on the lateral side, because the medial side is equally as friendly for percutaneous placement. Obviously, as you get more proximal, you have to be careful of the artery. Next is, are you going to create a non-union by having too stiff a construct? So this is a study by our moderator, Dr. Scalero, where they had all the different constructs: a lateral plate, a retrograde nail, dual plate, a plate nail. And they first looked at the axial torsional stiffness in a synthetic model. And certainly the dual plate had greater torsional axial stiffness as compared to certainly the single plate, but also several of the other constructs. So it certainly is, can present a stiffer construct. And then they did the same thing, just looking at the plate nail and dual plate, looking at torsional axial stiffness in cadaveric specimens, and showed that, there's just significantly greater torsional axial stiffness with the dual plate. So while it's certainly a concern, so this is like a pseudo method, it's a concern, but it's something that we can modulate. So we can either use non-locking screws on the proximal end. We can have a more balanced construct. You can think about using titanium as compared to stainless steel. So there are a lot of different ways to modulate the stiffness of a dual plate construct, and something that at least I pay attention to when I'm planning to do a dual plate. Last is, you're limited by how proximal you can go on the medial side. And that's just really not true. So this is a study done by Corey Collins where they looked at CT angios and had 3D reformats performed. And what they found was, on average, if you went from the adductor tubercle to the femoral artery along the mid femur, on average is 16 to 19 centimeters in length, which is, you can get pretty proximal. If you then go to more of the anterior femur, it is up to 23 centimeters. So you can get fairly proximal with your medial plate. Obviously, the more proximal you go, you'll want to do more of an open approach to make sure that you're not going to do any damage to the femoral artery. So here's a quick case example. So this is a patient who she's 72-year-old female, presented outside hospital with this kind of spiral distal femur fracture that we commonly see. And then you'll see these images in the middle where it kind of shows some signs of distress, where there was a struggle. You can see multiple lag screws in the metaphysis, which is totally fine. But I think it's telling on the lateral. You can kind of see the erosion of the anterior cortex, where they probably placed a few big lobster clamps and kind of cracked the femur. Anyway, so they devascularized this kind of metaphyseal zone, and predictably went on to non-union. She broke her plate. And so then she presented to me, and this is back when I didn't really do dual plating, so I thought I'd do a plate nail. And as you can see, it's a really short segment of intact bone between her femoral arthroplasty and the fracture site, but I thought I'd still get a nail, a shorty nail in place. And so we did these kind of tricks to drill and then place the nail, and then we have an interlock that's just barely in the proximal end. But I thought we were in good shape. Well, it turns out we weren't. So you can kind of see how she predictably failed with very little fixation from the nail. She started failing to varus. And so we revised her with this long medial plate, which I wouldn't recommend using. It's a 4 or 5 stout plate. It requires a lot of bending, but it just shows that you can get fairly proximal with the on the medial side up across a total hip arthroplasty implant. And this is her at 6 months. She's spot welded on the medial side, not so much on the lateral side. And so my learning points for this case were, like, situations like this, probably not ideal for a intramedullary nail support, and that you can get really proximal with the medial plating. Okay, so some technical tips on doing your first or maybe doing your next one, at least for me. So what we commonly get is, which plate do you use on the medial side? So there are only a few vendors out there that have medial distal femur plates currently on the market. And so we're left trying to figure out how we're going to do this. So you can certainly contour and bend one on your own. That can be a little time consuming. So these are 3 commonly used plates, at least that I've come across: the proximal humerus, the lateral tibial plateau, and the medial distal tibia plate. And so we did a study that on sawbones, where we attached these plates distally and then made a cut and used the OptiTrack to measure their amount of translation, angulation, and rotation. And it turns out the lateral tibial plateau plate seems to fit the best. As you can see in these fluorospots, they all produce some amount of varus, but at least the lateral plateau plate produces the least amount of rotation and least amount of sagittal plane translation. So this is the one that I'll commonly use now. I've tried the proximal humerus. I've tried bending a few. I haven't tried the distal tibia, and clinically, I agree with these results, in that the lateral plateau plate seems to produce the least amount of deformity. Your follow-up question could be, well, why would you even bother with that? Because aren't you just starting with the lateral side typically? And my answer for that is not always. So I think traditionally I will start on the lateral side more often. However, I think there are situations where I think starting on the medial side, or at least addressing the medial side before you completely fix the lateral side, makes a lot of sense. And so situations like that, where I'll start on the medial side, or where there's a lot of medial translation, or there's a significant amount of varus, I will start on the medial side to correct the coronal plane malalignment. That being said, I'm presenting this one, which presents in varus. So you might be like, well, why are you presenting this one? So here's a quick look at it. You can kind of see I know there's a lot of artifact with the CT scan, but her medial side is a little bit segmental. Lateral side super low. And so what we did intra-op was I placed this lateral plate with a single screw, just to kind of create a backstop. And you can kind of see she's still translated medially. And you could maybe pull that over with clamping or something like that. But instead, I elected to go medially and place a buttress plate. It's a non-locking screw to kind of correct her coronal plane alignment. And I was happy with how that actually reduced our fracture. And so that here she is post-op at 6 months. I let her walk right away and heal without any issues. So in summary, I think like I reported the early results on our study, this is rarely performed, dual plating. So while you're in your fellowship, I encourage each of you to seek out attendings that are willing to perform this so you can get a little experience with seeing how dual plating goes, because there's certainly situations where I feel like it can be very useful. I'll typically use it in these unnailable or patterns like super distal, distal femurs, or closed box, or some of the other situations I presented. I think these constructs are great because they allow immediate weight bearing and control things well, both actually and torsionally. Dual plates are amendable to metaphyseal healing, so long as you do this in a soft tissue sparing or friendly approach, and which can be done on the medial side. And in my opinion, the proximal tibial plate induces the least amount of deformity and is the one that I'll typically use it currently. Thanks.
Awesome. Thanks, Justin. Marshall loads things up. Just maybe a quick question. Are you doing this more frequently open, or are you doing this through windows as was shown in Rafi Neiman and Finkmeyer's paper?
Yeah, I'm doing it pretty similar to what Neiman and Finkmeyer do, where kind of small medial incision distally, and then a small incision proximally, just to make sure that the plate's in a good position and placing screws. Depending on how proximal it goes, so if it's a really low fracture medially, I'll even just do it not percutaneous, but smaller incision than what they presented on their paper. I never open the full medial approach or anything like that. It's all fairly minimally invasive.
Great. Awesome. All right. Marshall Burks from WashU.
All righty. So let's talk about the combination of nails and plates. So we'll talk a little bit about why would you do this, and then what works, what doesn't work, some of the things that you will discover over time that matter or perhaps don't matter, but you should take note of. Dr. Scalera already, I think, fairly well outlined the problem. Getting these fractures, distal femur fractures, to heal can be challenging regardless of what sort of construct you're using. And this is all compounded by, and anybody on this webinar knows that these patients are a real problem. Their bone quality can be pretty much deplorable, and their overall health status is not far behind, if not worse. So really, it's an absolute challenge. And really, this is the hip fracture of the knee, which is to say the mortality rates are pretty high. Again, reflecting a symptom of just overall poor health. And so when we're taking care of hip fractures, the goal is to get them up, mobilize them, try to give them the best shot possible to avoid all the associated complications and potential mortality. And so I think the exact same applies here. And so our goal is for distal femur fracture, and I'm speaking in specifically about the geriatric population here. We want to have the immediate weight bearing for mobilization, but also we want the fracture to heal. So what is this sort of secret sauce or special formula that we're going for? And so nails work okay, plates work okay, but if we combine them, is that potentially better? And so there is some small case series that do report pretty good results. None of this is like the most scientifically robust things that you will find, but you and probably have seen in your own training that this is becoming more and more common. So I think it is a promising technique. And so for me, talking about or thinking about when would I do such a thing, combining a nail with a plate to treat a distal femur fracture, I think pretty obviously, if the bone quality is bad and they can't protect their weight bearing status, vis-a-vis geriatric distal femur fracture, that's a real good indication for that. Additionally, if they're larger and it's just, again, simple mechanics, you may not have much confidence in a single implant, particularly if the fracture is comminuted in conjunction with the bone quality issues. Non-unions, I think there is a role, and a lot of these patients will come to you and they've been kept non-weight bearing for 6 to 12 months, and it's like they just want to get on with their life. So maybe you can apply a treatment that'll allow them to get weight bearing quicker, or maybe adding to whatever is in place to get the fracture to heal. So when not to do this, if the prosthesis is loose, not a good idea to fix. I think that, then we get into the domain of revision arthroplasty. And I'm not a get out the metal cutting burr and create a box kind of guy. That is described, but if it's a closed box, then it's just not going to be nailed. And then, I've kind of gained appreciation over time that nailing to a really posterior box is just not a good idea, because it's going to result in a deformity. So you should think twice about that. People will talk about if the fracture goes distal to the anterior flange of the total knee, that you shouldn't fix those because it's, it's quote unquote too distal. Personally disagree with that, but this is all open to interpretation. And there are some where there's splits going down into the prosthesis and the coronal plane. I think some of those can be fixed. That really just boils down to, is there enough intact bone that you can get devices into that's going to hold up over time. This paper, which goes with, which total knees are compatible with retrograde nailing. This is the Journal of Arthroplasty in 2014. I think it's been updated, but actually a very useful paper that you should check out, because it can give you some rough guidelines based on the geometry and the specifications of the prosthesis. So here you go. This is a posterior box procedure performed in my youth, and you can see exactly what happens, right? It's just a posterior start point, and it's going to lead to recurve bottom. And so if you're having to flex the knee over a triangle just to get a reamer in and get the nail in, you can anticipate exactly what's going to happen. They may enjoy the fact they no longer have a flexion contracture, but it just doesn't make for a pretty x-ray. So here you go. If you're encountering this is probably something smarter to do, or consider a different way to treat this with not per se an intramedullary implant. So talking about the nail plate combination technique, and we'll get into a little bit of the pearls, pitfalls, etc. This is a great article. I urge every one of you to read it if you have not already. It kind of goes through in a stepwise fashion how Dr. Liparachi and Yoon go about applying this. And so one of the questions is, well, do you nail it first and then plate, or do you plate and then nail? As I think about it, and as I've done it, for me personally, it's just easier to plate around a nail rather than nail around a plate in terms of dodging traffic and so forth. And if you get pretty decent with your starting point, your trajectory, and achieving alignment with the intramedullary device, you can get a really great indirect reduction. So I think the nail first option is really predicated on a good nailing technique. So here are some things that I've just, found that can be helpful in a less invasive sort of fashion with the nail first approach. And so, if you may see this where the shaft is translated anteriorly, and you're just struggling to get that, and you can just slip an elevator in and then just crank on the flange and bring it into better alignment, and then off you go and you nail it. Blocking wires, very useful. They're a little more forgiving than blocking screws, which in really brittle bone may just fracture through, and you lose the effect of the this blocking device. So blocking wires, think about it if you're running into translational or angular deformities. This is a move that I perform with frequency. You know, manipulating really soft bone can be difficult, but pulling metal a little bit easier. So if you need to adjust the sagittal alignment, you can just hook the flange and pull it out of recurvatum. Find that helpful. So plating first. When would you plate first? Well, there's no absolute answer to this, honestly, but again, as I think about this, in cases where you're really struggling to obtain or maintain a reduction, usually it's in the sagittal plane for me personally. I may think about plating first. So this is just one such instance. This is a non-union, pretty significant deformity for starters, and just really having a hard time controlling the distal femur. And at some point, you can see the stigmata struggle with intracortical mini frag plates and screws. But anyways, finally decided I'm just gonna get the alignment and hold it with a plate and then nail around it, and that turned out okay. The issue of linkage, it's real sexy. Some people are really into it. This is, unitizing the constructs, putting a screw through the plate, through the nail. Is it necessary? I don't think anyone knows the answer to that. If you are going to do it, this is a way I found that it can be helpful, and it's helpful if you leave the nail jig on, and then you can kind of line the plate up with the jig and then pass the screw through both implants. I have gotten opinions either way. Yes, it's great, it's amazing, you have to do it, or this makes it too stiff and leads to early failure of the implants. So I have kind of moved away from it just from a practical standpoint. I personally don't think it matters all that much as long as you have good fixation otherwise, and it is a little bit more time consuming for me personally. So here's the other issue with when you do that, you place a screw through the plate, through the rod. Typically what happens, and this all depends on the alignment of the nail, but the plate on the distal femur is meant to sit, with a 10-degree internal rotation on the surface of the femur, but it's going to externally rotate as that screw passes through the nail. And so that may not be awesome. It's going to be sitting off bone. Maybe that bothers you. I don't know. But the other thing it does, which sometimes can be helpful, is that it externally rotates the plate, so it's a little bit better on the proximal femur. So that's kind of like, oh, that worked out okay. But that's what I found does happen. It's not going to sit really nice on the distal femur if you try and pursue the linkage strategy. So then you can say, okay, I'm just going to make the plate fit to the distal femur where it belongs, and that's easy enough. Although, as you may have encountered, these plates may not fit anybody very well, especially in the arthroplasty population. But if you do get it plate to bone, that plate is, again, meant to sit a little bit anterolateral, and so that's where it's going to sit up in the proximal femur. And so if you're trying to perform neck fixation, and that's a whole nother conversation if that actually does anything or not, but it becomes pretty difficult to get screws up into the head and neck that are sort of in line with the axis of the neck, just because of the location of that plate, which is a little bit anterior. And sometimes it can be just straight up impossible because of the location of the plate, the patient's anatomy, their version, and all that stuff. So just some things to think about. Here's a possible solution for such an issue. And this is in the Liberace-Yoon technical trick article. They talk about putting a torsional bend in the distal femur plate, so you can have it sit where it's supposed to on the distal femur, and then it can come around and sit a little more directly lateral as it resides proximally. Personally, I've never done it. Maybe I'm going to start trying it, see how it works out. But my concern here is that the percutaneous jigs and outriggers that you might be using, and I would submit to you should be using to perform a less invasive approach, those may not work once you start bending the plate. Here's a fairly common scenario. Big fan of short nails because they support my peri-implant fracture practice, which is just fantastic. So, you know, you have these issues here, right? Like they had a hip fracture, and so they're, again, this is a fragility, just global sickness, health problem. The whole point of fixing the hip fracture was to get them up and mobilized, and then now we have the exact same problem at the bottom of the femur. These may not be fixed expertly, or they may have had secondary displacement, whatever the case is. So hopefully it's healing or healed. Hopefully it's not failing. Then you got a whole nother ball of wax to deal with. But you can still do this technique with a nail if you have a reasonable working length and a nail that's the right length to fit. So you got to measure that out, think about it. All the manufacturers make these short retrograde nails of various lengths. So just depending on what vendor it is, you have to know those lengths if the technique is going to be doable. So this is just this case here. Nothing fancy. The fluoros on the left, you can see just a good, I think, nailing technique in general, which is to clamp the displaced cortex to the nail if the one side is comminuted and you can't really apply clamps to the bone surface itself. So that all works pretty reasonably well. And yeah, healed. She's got a CT of her hip or sacrum or something for some reason, but she's okay. Here's another very, very common situation. Total hip above, total knee below. You can nail plate it if the prosthesis allows. You just have to think about, again, nail lengths. This is a problem sometimes, the cement plug, and what it does is it tends to push your reamer posteriorly. So I have gotten in the practice of just getting it out of the way. It doesn't loosen the prosthesis, but you just have to work a little bit to get it out of your way so that the nail can go where you would want it to achieve optimal alignment. You can do it antegrade. That may be a little bit more appealing for total bone protection, you know, a large lag screw into the head and neck, which would probably more effectively prevent a hip fracture than a 4 or 5 screw or something like that. Same principles apply, just good alignment, good starting point, ending point, and it really is about, is there sufficient fixation distally? So don't forget about that. Non-unions, you can do it in non-union cases. This is a situation where I just left the nail in place, plate around it, compress it, and actually got a couple of these screws through the nail distally after we had compressed. So here's a newer type of device. You know, thinking about indications, great big large person. I want as much distal fixation as possible. Doesn't really do anything in terms of plussing up your proximal fixation, but I would say in general the failure point seems to be more of a distally based problem. So something to consider. I don't know if this is a panacea per se, but it can work out. And then I've done some other things here and there for various different reasons, but this is just an intramedullary fibula inserted just like a retrograde nail. This was a sort of minimal ambulator, but pretty deformed, displaced fracture with pain, so on and so forth. And so the bone quality was just atrocious. So we give her better bone quality with someone else's and then just plate and get fixation through the fibula, proximal and distal. So you can do it like any which way you want to, and they all can work. They can all not work. It's entirely up to you to give the patient the best chance possible. So this is kind of like my preparation du jour here. I will nail first. I'll use a shorter nail just because I don't like to futz around with getting screws around a nail. So I have a segment of femur that is not interfered with, where I can get fixation proximally. This is, you know, reasonably flexible in a relative stability secondary bone healing kind of way. I try to protect the whole femur, but the x-ray that you see is the one that you get typically with the location of the plate and the location of the screw. Does that prevent a hip fracture? No idea. Typically, I don't try and link the implants unless it's just out of serendipity, and try and do this as percutaneously as possible and let them walk.
Awesome. Thanks, Marshall. I'm going to jump on as you relinquish control there. Just a quick question. One of the things that people will ask frequently is, size of nail. And so do you have any thoughts in terms of, nail diameter that you talked a little bit about length, but are you always, using an 8mm nail or 9mm nail, or do you want to get the most robust, nail possible that you can put in the distal femur? What's your take on that?
Did you publish a study on this?
Maybe. Just asking.
I mean, I think it's common sense sort of thing. Like if it's a stovepipe femur, that putting a 10 in where you can slide a 11.5 reamer up by hand and have zero interference whatsoever, I think it makes sense to try and fill that thing up. These things where it's I don't think you have to push it to the max to get crazy interference fit, but more is probably more to a degree. But the more you fill up the femur, the little bit you have to contend with where the screws are going to go too. So I do think about that in terms of it consuming real estate.
And then last question, number of interlocks that is kind of the minimum for you in the nail. If you're going to be doing a plate nail and you have the nail in place, you have a minimum number of interlocks you want going through that nail. Is one sufficient? Do you want 2, 3? What's your take on that?
Probably 3 is usually what ends up happening. And I know it's not a purist move, but I have put interlocks that cross fracture planes. To me, it's just about kind of max stability. But 1 would make me uncomfortable. But I guess you have to just kind of consider what's, how comminute is the fracture, how much inherent stability are you dealing with here? What's the reduction like? What's the patient like? Are they 400 pounds and so on and so forth? But 3, short answer.
Okay. All right, so let's get into a couple of cases. 65-year-old male, motor vehicle collision, came to us 4 months after primary total knee arthroplasty. So these are the images that we have, and so pretty low periprosthetic distal femur. This is a cruciate retaining knee. You can see that there's no box. I don't know what my take is on these CT scans. You get a lot of artifacts. Justin showed a CT scan, so sometimes it's helpful. I don't think I can assess whether an implant's loose or not via the CT, but let me go back one. Justin, let me throw this to you really quick. Is this a one where you consider dual plating, limited opportunity for distal fixation? Are you giving up on this? You're going to do a DFR? Do you want a plate nail isolated implant? What are your thoughts pretty quick, and then I'll pass it to Marshall.
Yeah, great question. I mean, I think DFR is a reasonable option for this one. I try to stay away from DFRs in general because they have more complications overall. They certainly allow patients to walk right away, but for me, given how low this is, I would plan for a dual plate construct. The concern also would be, I'd have to look at that CT scan again, but usually our dual plates end a little more proximal than like the where that lateral proximal tibial plate sits. It may not truly capture all of the fragments on the medial side, so I might have to contour something a little more low profile, like a 3-5 or something like that, so it's not so bulky on the medial side. But I'd probably plan for a dual plate for this one.
Marshall, open box, what are you thinking? You with Justin here, or are you gonna stick with your plate now?
Well, first of all, I agree with your comment that I mean, I think the CT is helpful to evaluate the fracture pattern, but anything with regards to the prosthesis is not very clear, you know, whether it's an open box or closed box. It's like, I want a resident to show me definitively that it's an open or closed box. I think plain oblique plane radiographs are the best way to determine what's going on with the box. Yeah, this is pretty low and pretty comminuted. I think the dual plate approach seems least unsavory, I guess. Let me put it that way.
All right. So I'm going to get an effort to kind of get through as many cases as possible. I have to echo, I loved when I was looking at your slides, you know, using instrumentation through the anterior, you know, directly anterior through the quadriceps. I mean, we cut through this all the time to put retropatellar tibial nails in, so there's no reason that instrumentation can't go through there. So get that flexion deformity out of there, and you can, you know, see that the void left by the distal end of the proximal segment kind of impacting into the femur, but get that flexion deformity, extension deformity kind of out, line the shaft as well as I can. You can see the cement plug that you were talking about before, kind of anterior. Things seem to be pretty well aligned. And then I actually started with a short plate, and I know you'd shown some constructs with very long plates. You know, I think we all have a little bit of a different take. I just, you know, this was so low that I was relying on that plate to kind of just give me a little bit of fixation, but was able to use a cortical screw initially and then swap it out to just improve my alignment, and then place a retrograde nail because I had the open box. And so this was my final construct, and the AP in lateral, and it was actually pretty satisfied. I think one of the things that's always telling, and I think you know, both of you can probably echo this, is when you get the posterior cortex aligned in some of these fractures, then you can see how bad the arthroplasty surgeons notch the femur. Now, granted, this may be in a little bit of extension, but you can usually see, you know, that's the reason that these things happen. So this was these are my initial post-operative radiographs. So thoughts really quickly. I do okay, Marshall?
Yeah, I think so. And you know, regardless of what you do, as long as that thing is where it needs to be, and just kind of potted onto itself, I think it can work out just fine. The things that are sometimes annoying, I don't know if it affects you in this case, are those pegs, because it may force you to drive the nail in deeper than you would like to, and so you start to lose interlocking options.
Yeah, and so let's go ahead, Justin.
I was just gonna say, I think this looks great. Out of curiosity, John, did you let her walk on it or him walk on it right away, or is this?
Yeah, I did. So I let this patient walk on this immediately. I had 2 or 3 interlocks distally, and so one of the other things that I was going to, you know, mention following Marshall's talk is, you know, a lot of these jigs allow for, you know, not only lateral to medial, but sometimes medial to lateral interlock. So you can take the ones that are designed to go lateral to medial and place them medial to lateral if needed to see if you can, you know, maximize opportunities. But so many of you may be unfamiliar with the California landscape here, but I let this patient walk, and then they walked right over to Kaiser, which is where they get provided most of their care. You know, nothing was a great, you know, outcome like a little bit of follow-up. So I reached out, you know, a little bit ago to one of my colleagues at Kaiser, and so this was at a year. Patient was still having pain reportedly, was deemed to have a non-union. Looks relatively well healed on that lateral, but you can see that medial cortex never really kind of filled in on that on the AP view. Patient was converted to a spacer, and then this is the last follow-up radiograph shortly thereafter. So I put this in because this is, you know, I was pretty happy with this, but these things are problematic, and so I don't think that there's any, you know, one construct out there that's a panacea. I mean, I think it, you know, doesn't even mention the DFR, and at 65, it seems too young for me. But and again, I don't know the exact decision making that went into this one, but this is, you know, this is kind of a real nice dose of humble pie. So when you go into this one, is a 75-year-old male. You see poor bone quality, already on home oxygen, and looks like an intra-articular. Justin, maybe you can comment on the complexity of the intra-articular fracture. I think this is your case, but native knee. Justin, can you remember how severe the intra-articular component of this one was?
Yeah, so this guy had a interarticular split and then a Hoffa fragment. I think you can see that on the lateral side or on the lateral radiograph. So Hoffa and then interarticular split. Doesn't ambulate a ton. 4 liters homo 2. Yeah.
Marshall, WashU, is this patient going to be seen by the arthroplasty service as well for a DFR, or is this something that you're thinking about fixing? Minimal or not, simple intra-articular, but then also a coronal plane fracture.
Yeah. I think the other thing to consider is that, if they're on 4 liters of home oxygen, it's not like they're running marathons, right? They just need a peg to get up and stand on. And I think a lot of times you can provide that. You're not going to necessarily prevent arthritis, although I don't know if this guy's going to continue to live long enough to get more arthritis than he already has. So I think this is going to, for me, just kind of glancing at it, I'd probably give it a go.
All right. So Justin, why don't you this is your case, why don't you just take us through your thought process here and what you ended up doing?
Yeah, so first we addressed that coronal split, that Hoffa fragment, and with these lag screws, and then we put together the interarticular split with a series of clamps and wires, and then I used I think it was a 2-4 plate along the anterior aspect of the distal femur just to kind of pull everything together. So we had some screws in that were lag screws across the interarticular split, and some screws that were locked into the plate that were kind of more posterior, just to kind of recreate this distal articular block. And you can kind of see that plate anteriorly. And so we're setting ourselves up to place a retrograde nail, using percutaneous shoulder hook on the medial side. And then again, like Marshall discussed, getting our a good start point so that we could have everything lined up. And then we placed our nail with 4 interlocks. We placed these screws just to kind of close down the space. Not really blocking screws. We placed the nail and then placed the screws just to prevent any type of motion, or kind of that bell clapper effect that Hassan Mir wrote about. Again, just to make sure that there's not so much motion across that metaphyseal segment. I thought this would be stable enough given this guy's activity level that he didn't need a lateral plate. I think you totally could have put a lateral plate on this as well, but I thought this was sufficient, and I let him walk on it with a walker.
Yeah, I really like the use of those screws in the proximal segment. We were talking briefly about nail diameter, but I think one of the other ways that we can improve stability is placement of these screws. And again, for those folks on the call, I think it's important to note that these were not placed. I mean, they can be placed 100% to help dictate the position of the nail within the shaft, but oftentimes, especially in my practice as well, will be placed after just to support that nail, almost to like goalposts. So nice. All right, so this is a 71-year-old male, slip on ice, had a total knee replacement in 2008, and so have this displaced kind of metadiaphyseal fracture. Looks like there's it's a post cruciate retaining knee. Almost looks somewhat similar to that one of those ones that Justin had showed previously. So Justin, when you see this 71-year-old male total knee, is this something that you're going to be thinking about using a dual plate construct on, or lock, single lateral plate, single nail? What's your thoughts?
Yeah, honestly don't do a lot of single lateral plate anymore. Just because for these patients, I'll want them to walk on it right away. And so, much like Marshall was saying, I'd be concerned at where you would get your start point on this. I don't know if it's a really posterior start point. I'm not really familiar with this implant, but that's something I'd be concerned about looking at as radiographs. So I get a CT just to see if I could identify how far posterior his start point would be. If it wasn't too bad, I'd plan to do just a single retrograde nail with some interlocking screws. If it seemed like it was fairly posterior, I would probably do a dual plate for this one, just because I think a nail would be challenging if it was a real far posterior start point.
Good. So single retrograde nail was placed to see a little bit of that extension deformity, likely because of the, just the position of that notch. Again, just because the box is open doesn't mean that once that nail passes, that's gonna disappear. Yeah, I think there are, we talked a little bit about some of the advances and changes in implants, and so there are some implants now that are coming out into the market, some that already are, that have a more aggressive distal bend to accommodate some of this. And so this is what was seen at 6 weeks. And so Marshall, I'm going to flip this over to you. What were your thoughts kind of at this time?
Yeah, this is like at the clinic visit where you look at it and you think, man, I thought it looked better than that. And then you go back and look at it. Yeah, it did actually. And so there's been some loss of reduction over time. It's too soon to say clinically, is this guy like doing terrible or doing great, or well, I guess if he's doing great, that might be obvious, but he's just kind of, it's painful. I'm trying to walk on it. I did let him weight bear. But yeah, this is concerning.
So now he's going on, he's getting a little bit of worsening pain. Things maybe starting to shift just a little bit. And so I can keep going, maybe just for the interest of time. But here at this point, you change lanes a little bit, huh?
Yeah, he was getting worse, and the proximal interlocks had broke, and now all the distal ones had broke, and so I felt like the cat was out of the bag, and so we decided to do this, which I had high hopes that was going to just overwhelm him with fixation and stability, and you can proceed. And I think technically it went okay. I didn't do any aggressive reduction or clamping or compressing or anything like that. This is still just trying to be as least invasive as possible and allow for secondary bone healing. But here we are now, another 7 months later, and it's nothing's happening.
Yeah, so you decided to change lanes a little bit here, and we've gone to the isolated implant, the retrograde nail. Now we've gone to the plate nail construct, and now we're off to the dual plate. So I think this is not, I hate to say this is a really unique case. I mean, this is something, these fractures are really challenging to get to heal. So why don't you just talk us through what you did here?
Yeah, so the non-union plane primarily, it made sense to get sort of a anti-glide or a buttress medial plate to compress against, and also tried lagging across it, which did work to some degree. And so I agree with Justin. This is a large fragment anterolateral tibia plate that actually fits most people reasonably well. To the comment or the question, are the medial implants bothersome? This one is 100% bothersome for this guy, but that's what we did, and then just compressed it after we had something to prevent shear on the medial side.
Good. So dual plated, and obviously checking for evidence of infection, stuff like that.
Yeah.
Oops. And
Yeah, he's done okay. I think it's safe to say it's probably healed 2 years later. But he's getting along, doing his thing. Inside part of his knee hurts wherever that plate is, and he doesn't want any more operations. I can tell you that much.
That's good. Great case. All right, so I'm gonna stop there and swap back over to is my conclusion slide up? Just want to make sure I'm doing this okay. Can you guys see it?
No.
Okay, I'm gonna stop share and then come back into it really quick. Sorry. So we're reaching about an hour. There's been some real good questions. Let me just take a quick look at the Q&A here. So one of the questions, the radius of curvature, the nail, the anterior femoral bowing in elderly patients. I think that's a real question, and that occurs both antegrade and retrograde. Marshall showed an antegrade nail that was used, and I have a case where you used a combined plate nail, but sometimes the radius of curvature, especially through the shaft in smaller patients, the radius of curvature is so small that the nail doesn't sit exactly where you want it. And then similarly, retrograde, sometimes when the nail comes in really posterior, then it's riding up along that anterior cortex. And so, there you really want to make sure that I think you bypass that segment with the plate and not worry about having a nail that goes way long into the proximal portion of the shaft of the subtrochanteric region. I think, again, remembering that the nail itself is just as a medullary support, it's an intramedullary strut essentially to prevent varus, I think, is the most important thing. So in conclusion, I'm going to wrap things up here, and then I'm going to give my panelists an opportunity to have their parting thoughts or parting words. Dual implant constructs right now, again, a lot of emerging data about them, including their use in primary and revision surgeries for non-union. The dual plate, to summarize, really short distal segments in a posterior stabilized total knee with a box. Even Marshall had talked about the fact that that's a situation where he's not going to be bringing out the metal cutting burr and exchanging polys and things like that. So a dual plate may be a good option, or a medullary canal that may be unavailable for whatever reason. Nail plate, those very cavernous distal diaphyseal, metadiaphyseal segments, these poor hosts, potentially long extended metaphyseal comminution, I think is another real good opportunity for a plate nail construct where you don't want a really long working length that's just going to allow for way too much motion for these patients, and then the desire to have immediate weight bearing. I think the order, for both dual plates and plate nails, the order of implant placement is less essential than the quality of reduction and fixation stability. And so you heard a lot from both Marshall and Justin talking about reduction techniques. And again, that needs to really be paramount. You can have, 2 implants, 3 implants, 10 implants, but if you put that femur in a position where it's biomechanically disadvantaged, I think that's a real problem. We heard about the fact that biology can be preserved when applying dual implants. Marshall talked about making nail placement and plate placement as percutaneous as possible when the opportunity is there. And then we saw some opportunities for just distal and proximal windows for dual implant placement. I think in some situations where a shear spike or an area needs to be keyed in, that may necessitate an open approach, but oftentimes you can do this in a biologically responsible manner. And then again, we saw the gadolinium MRI study that Justin showed initially. And then for both, really, in these patients with poor bone quality, combined implant constructs allow for immediate or at least earlier weight bearing for many of them. So I'm going to, again, pass it off really quick. Maybe Justin first and then Marshall, just any kind of parting thoughts on not only your position with regard to dual plates or plate nails, but maybe just thoughts on the topic in general. So Justin.
Yeah, so I think this is still one of those topics within orthopedics and orthopedic trauma what is still controversial. We're still trying to figure out how best to treat these patients. And I think we have to think about these in a similar manner as geriatric hip fractures, kind of like John was talking about, and also Marshall was talking about, because we really need to encourage early weight bearing to limit some of these diseases that we're coming to see. And so whether that's, increasing your fixation or increasing the amount of screws that you have in your plate or whatever it is, I think we have to really get away from restricted weight bearing in these patients and move towards early weight bearing mobilization.
Marshall?
Yeah, there was a question about range of motion in the Q&A there. And I certainly don't restrict them. I don't do anything like CPM or anything above and beyond telling them, hey, move your knee and get going and work with physical therapy. And I got to say, probably as a function of most of these that we're talking about tend to be elderly, stiffness is really not much of an issue other than the pre-existing stiffness they had before. They all typically recover their range of motion. It's pretty rare that that doesn't happen. Aside from that, as Justin alluded to, if you're in your fellowship year, yeah, like kind of push the envelope a little, have your, see if you can talk your faculty into trying technique this or that, or just experimenting. And once you get into practice, I would say you're going to be well equipped to undertake a lot of seemingly difficult problems, and they are difficult problems, but you abide by the principles and do what you've been taught, you can tackle these things. So don't be afraid to give these patients a shot, and I think you'll be surprised.
Awesome. Well, thank you. So to Marshall and to Justin, really appreciate your efforts. A big thank you to the AO Trauma North America staff for putting this together and keeping us on task. I placed our emails on this last slide here in case you have any questions. We tried to maintain an active eye on the Q&A box, but things may come up, and so please feel free to reach out to any of us. And with that, I'll wrap up. And thank you very much. Appreciate you all tuning in.